Parkinson's disease is second commonest neurodegenerative disease, affecting 1 to 2% of the population over age of 60. Managing advanced Parkinson's is a complex affair. There is growing recognition that GI dysfunction is common in Parkinson's disease, and virtually the entire gastrointestinal tract can be involved, causing problems from dribbling to defecation. As the disease progresses, 70 to 80% of our Parkinson's patients develop dysphagia and also life-threatening aspiration pneumonia. Initial years with oral treatment, what we call as pulsatile dopaminergic treatment, looks good and funky. As our patients sail through to the advanced stage, advanced Parkinson's disease is complicated by erratic gastric absorption, delayed gastric emptying, medication overload, poor levodopa absorption. This henceforth can cause on and off non-motor fluctuations, dyskinesias, initially predictable dyskinesias, and eventually unpredictable dyskinesias. Once unpredictable dyskinesias hits in, one should start looking at non-oral options. Perhaps to start with, transdermal rotigotine patch may be advised, although it's not clinically effective. In this situation, we should start looking at non-oral infusion options like subcutaneous apomorphine, intrajejunal levodopa infusion, and of course, conventional deep brain surgeries. If we look at NICE UK, National Institute Centre of Excellence UK, guidelines and recommendations for advanced therapies, essential concept is based on offering best medical therapy. This of course depends on the available options in respective countries. For example, in UK, NICE advocates subcutaneous apomorphine before considering other non-oral infusions like intrajejunal levodopa and deep brain surgeries. Whereas coming to Middle East and Gulf countries, if you look at intrajejunal levodopa infusion, the best evidence we have based on large observational long-term observational study, the Gloria study, which indeed showed in large cohort of advanced Parkinson's patients the long-term safety and efficacy of duodopa. And duodopa is nothing but, it's a traditional levodopa in a gel form, comes in 100 ml cassettes and holds around 2 grams of levodopa, and this should be stored between 2 and 8 degrees centigrade. If we look at intrajejunal levodopa infusion, and based on the data, especially the long-term observational study in a large cohort of advanced Parkinson's patients supporting long-term safety and efficacy of duodopa on motor and non-motor symptoms and quality of life scores. There was significant reduction in dyskinesia scores, and coming to whether it's an intrajejunal levodopa infusion or a deep brain surgery, there aren't any head-to-head comparisons, no obvious robust data. However, the expert consensus reports or clinical experience and anecdotal studies indeed showed intrajejunal levodopa infusion is a preferred option in elderly individuals, and also where deep brain surgeries is contraindicated. For example, the patients with neuropsychotic symptoms having problems with depression or suicidal thoughts, or patients with fluctuating memory or cognitive problems, or patients with speech and swallow problems, or patients with excessive comorbidities like diabetes, etc., and also restless legs, where duodopa is the preferred option in here. Five prerequisites for a successful duodopa implementation. Number 1, patient selection, training and organization, dose optimization, follow-up and monitoring, and patient and carer education. The key first step for best optimal therapy response is patient selection. Usually idiopathic Parkinson's disease over 2.5 Hoehn-Yahr scores over 2.5 or 3, with at least over 20% levodopa responsive, and of course any failed or refused patients for DBO surgeries will be a good candidates for levodopa, and should have, of course, accessible to gastroenterology, therapies, and expert nursing and radiology will be a paramount for successful implementation of levodopa. Personally, I recommend nasojejunal response test for every patient before implementation of patch. The reason for that is we'll get, by doing nasojejunal response test, we can able to set the dose adjusted to best optimal clinical response for individual patient needs. So dose optimization depends on previous dopaminergic regime of the patients. Thereafter we convert them into levodopa conversion factors, equivalent dose, and we can able to set early morning dose, continuous maintenance dose, if needed extra bolus dose. At our centre, National Parkinson Centre of Excellence, King's College Hospital, London, every patient will go a thorough evaluation of motor scores, non-motor scores, fatigue and sleep assessments, and also quality of life scales. And also each patient and carer will be primed, get hands-on training, pump training, and also stoma care management. And each patient and carer will be primed of potential side effects like connector leaks in the connectors, gastric fluid leak, and PEG site management, and of course exceptionally rare side effects like peritonitis and organ perforation. These are exceptionally rare, and I've only seen 2-3 cases in last 20 years of doing implementing levodopa. During the current COVID climate, I can't conclude without saying few words about COVID-19 and Parkinson's disease. Parkinson's disease per se doesn't carry any risk of catching COVID-19. However, most of our patients being elderly individuals, some of them having multi-comorbidities like long-standing diabetes, respiratory problems like asthma, COPD, some of them having kidney problems with long-term dialysis, and of course patients on long-term steroids pose a high risk of getting COVID-19. For these type of patients, I personally recommend 2 types of precautions. One, general precautions, say for example, like we all come across washing hands quite often with the soap, at least 15 to 20 seconds, both inner and outside fingers and front and back of your hands. If there is no soap, you should use a hand sanitizer with at least 60% of alcohol. Avoid touching eyes, nose and ears with unwashed hands. And also please avoid any crowds, especially during the festive time. I strongly recommend to avoid huge religious gatherings, so that we can try to avoid any sick patients. You should strongly engage to be active, engaging in remote technology by using laptops, your phones, social media, etc. And one advice to all my patients I gave is all the elderly patients should get vaccinated against pneumonia, as COVID-19 can pose life-threatening pneumonia. And treatment-specific precautions for patients, especially for levodopa, I recommend to stock up necessary required cassettes and supplies at least for a few weeks. Avoid non-essential travel. If in case any dire emergency you have to visit your local hospital, that make sure you carry your treatment certificates and all your consultant clinic letters, your Parkinson's disease nurse specialist contact number or your community care coach contact number. And also make sure you carry your patient pump manual, training manual, as some of your doctors at your local hospitals may not aware of these advanced therapies. And also I would strongly recommend to hydrate yourself with lots of fluids and vitamin C or in juice to boost your immune system to avoid unnecessary urinary tract infections. That's one of the common costs which I'm seeing now since last 2 weeks. My Parkinson's patients most of the patients getting admitted to the hospital. And one more advice to the carers and caregivers is please take extra precautions to avoid bringing COVID-19 home. We at National Parkinson's Centre of Excellence, King's College Hospital London, pioneers implementing advanced therapies for Parkinson's disease like G-dopa, apomorphine. Over 2 decades, we now started our advanced therapy implementation program at our King's College Hospital London. We have exceptional faculty, state-of-art infrastructure, well-renowned in-house neurology team led by Dr. Vittorio, world-class visiting faculty, Professor Ray Chowdhury, and gastroenterology team led by Dr. Guy Chung Fei. The entire G-dopa implementation program at King's College London, Dubai will be under my direct supervision. I'm pleased to share with you, we successfully implemented one G-dopa patient last month, and I want to convey my sincere thanks to King's Dubai team, APD team, and Manzil Richal for making the first G-dopa patient at King's Dubai a great success. And I'm sure I'll share the patient testimonial where a gentleman who served his country for 40 years was wheelchair bound for 2 years, now able to carry on his activities of daily living all by himself. Thank you.